everybody, it's Caitlin. Welcome back to CoronaChat. Tonight is Tuesday, April 14th, and we're going to talk a little bit about racial disparities. So over the last few days, you might have noticed an uptick in the number of news stories talking about racial disparities in COVID-19, and particularly the fact that Black Americans appear to be dying from COVID-19 at really disproportionate rates. So in today's episode, I want to bring us past those headlines and down to the numbers. What do we know? What do we not know? And why does this information matter? And explaining all of the possible reasons why communities of color might be disproportionately affected is complicated. And it will take far longer than the few minutes we have here tonight. But there's a great special episode of NPR's CodeSwitch that does a really nice job of teasing all of this out. And I'll put that link in the show notes for us. But the top line is that it boils down to the legacy of racism in the US, and it's not due to any kind of biological or genetic difference. So with that said, let's get down to the data, and let's start with what we know. So at the beginning of the month, there was very little discussion of racial disparities around coronavirus. But a week into April, some experts in racial disparities and health equity in the United States were beginning to call for data to be disaggregated by race and ethnicity. And based on what we know across basically every issue in public health, there's reason to believe that coronavirus might not affect all communities equally, despite many in the news referring to the disease as a great equalizer or an equal opportunity infection. Now, the transmission of a respiratory illness, like coronavirus, for example, can be stopped or slowed by social distancing. But if you can't social distance because you're an essential worker or because you share an apartment or a home with many other people and there isn't enough space, then public health officials telling you to stay home is ineffective at best and maybe even feels like a slap in the face. Right? In the US, the legacy of racial discrimination contributes to differences in people's ability to accumulate wealth, buy homes, and access the kind of education and jobs that let you work from home. Because of this, many experts in health disparities in the US expected that COVID-19 would also affect communities of color differently. As a quick side note, similar realities exist in many other countries as well, though they may be marked less by race and more by social class or caste or other social hierarchies depending on that country's history. But it's a truism of public health that communities that face discrimination and limited access to resources are more vulnerable to public health crises. Right? So in the past week, some cities and states have begun releasing figures that are disaggregated by race and ethnicity, and the results in many cases are quite alarming. For example, in New York City, 34% of known deaths due to COVID-19 are among Latinos, even though they make up just under 30% of the city's population. In Louisiana, 70% of known COVID-19 deaths are among African Americans, though they make up only 32% of the state's population. On the Navajo Nation Reservation, they're reporting 813 confirmed cases and 28 deaths in a total population of around 350,000 people, so the rates of infection are quite high compared to other parts of the country. And depending on whose data you look at, Asian Pacific Islander DESI communities in California may also be suffering disproportionately. At this point, whose data you look at is really important. Right now, we're not getting disaggregated data by race and ethnicity in all states. And even though the CDC is starting to release racially disaggregated data, the agency doesn't have it for all states. And even the states that are reporting racially disaggregated data, they don't have that information about race and ethnicity of the patient in all cases. And so it's very hard to tell what's going on. This is compounded by issues in testing. So if, drive-through rapid testing locations are mostly located in wealthier white communities, then we have an undercount of how many people in other communities have been infected. This then makes it hard for us to know whether the virus is more widespread in certain communities or causing more severe illness or both. Right? So we need all states, territories, and tribal jurisdictions to include data on race, ethnicity, and tribal enrollment status in their testing, hospitalization, and death figures. And we need CDC to report on all of this too. And understanding this is important because it drives action. Action in this case might mean things like deploying ventilators and PPE to hospitals serving communities that are hardest hit. Right? It might mean pushing hard to develop information and health education resources in other languages. And once we have proven treatments and vaccines, it might also mean making need-based decisions on how to divide up available resources so they go to the communities that are most affected. Okay, so hope that was helpful for helping distill down some of this information. But onto your piece of good news. So on Saturday, the World Health Organization released a draft document that lists all of the potential vaccine candidates, and there are 70. 3 of those are already going into clinical trials, and 67 are still in preclinical testing, so if they pass that, then they'll go on to clinical trials. This is amazing progress, especially when you consider that just a few months ago, most of us had never even heard of coronavirus, and COVID-19 didn't even exist. So as we learn more about these new vaccine candidates, I'll be sure to keep you updated. Tomorrow, we're going to talk a little bit more about symptoms, and particularly symptoms of mild COVID-19 and what to expect if you do get infected. In the meantime, stay safe and take care of each other, and we'll see you back here tomorrow.